With the prevalence of IBS and its impact on workforce absenteeism and healthcare costs, it is clear that IBS diagnosis and care needs to be as cost-effective as possible. In 2009, the American College of Gastroenterology formed a task force to develop an evidence-based position on the diagnosis and management of IBS. According to the 2009 ACG recommendations for the diagnosis of Irritable Bowel Syndrome, treatment of IBS is tailored by the severity of symptoms and their impact on quality of life. Diagnosis is made based on the patient's report of their symptoms and by ruling out other causes, such as Crohn's disease, colitis, or celiac disease. Obviously, the process of ruling out other diseases is costly and time-consuming. Evaluation for IBS will include a physical examination, family history of cancer, IBS, or food allergies, as well as other laboratory studies, including stool for occult blood and complete blood count. If warranted, based on symptoms and geographic area, further labs may be indicated, including stool cultures for ova and parasites, blood work on sedimentation rate, and serum chemistries. Sigmoidoscopy and/or colonoscopy may be ordered, especially for patients over the age of 50, due to the risk for colorectal cancer. In younger patients, a colonoscopy may be performed based on the presence of certain conditions, such as weight loss. Other therapeutic trials and imaging studies, such as lower GI series, may be warranted based on symptoms and physician judgment. Once other gastrointestinal diseases have been ruled out, the diagnosis of IBS will be made based on the presence of specific symptoms as specified by diagnostic criteria. The two most commonly used diagnostic criteria are the Manning criteria and Rome criteria, which we will discuss in more detail in a few moments. Since the presence of one symptom is not sufficient for a diagnosis, the syndrome is diagnosed through the presence of a complex of symptoms, as specified in the diagnostic criteria. In the absence of alarm features and a family history of other GI diseases like inflammatory bowel disease and colorectal cancer, the diagnostic approach for IBS is to rule out other diseases. Alarm features are symptoms that are indicative of other gastrointestinal diseases, like colorectal cancer, celiac disease, and inflammatory bowel disease. Some examples of alarm features are rectal bleeding, nocturnal abdominal pain, anemia, and weight loss. In diagnosing IBS, the presence of IBS symptoms as specified in the Manning or Rome criteria with the absence of alarm features further supports the IBS diagnosis.